This is Carol from STS. This is the version 6.23 upgrade call for congenital. We're going to start on the postoperative section. On the line with me today from STS, I have Leanne Jones, Emily Conrad, Chastity, and Leslie and Melinda. From IQVIA, we have Jean and Joe, and then we have our surgeon representatives, Dr. Jacobs and Dr. Supermanian. One thing I just want to do before we get started with the upgrade in the postoperative section is discuss that STS had to put login, had to put password protection on our data resource collection. So I just wanted to show you, I just wanted to show you that when you, and I think I'm already logged in, so I probably won't do this for me, but when you go to registries, STS National Database, and you select the registry and go to pull down the access data collection resources, it now says login required, and there's some information here about if you need assistance to contact member services. Once you click this button, you'll be prompted, you'll see this login screen here. I didn't see it because I'm already logged in, but you'll see this login screen here. This is your login that you used if you attended AQO this year. So it's the same username and password. If you forgot your password, click the Get Started button and that will help you. Otherwise, please reach out to STS membership at membership. I believe it's membership@sts.org, or just click this hyperlink here. That went in place earlier, I think yesterday or late on Friday. So it's something new and I just wanted you all to be aware of it. Okay, and where are the slides? There they are. So we're going to start with the postoperative section today and then Q&A. Today is May 3rd. I hope to get through the discharge readmission section, and then we'll do anesthesia on May 10th. And if needed, we'll have another call for additional questions, or we can hold off until after go live, maybe the beginning of February, after folks have time to use the version to go through dedicated Q&A session for this. Okay, I'm going to hand this over now. To Chastity to go start with the postoperative section. On the screen here, we have the two forms. On the right is the new version 6.23 form that will go live January 1st, 2023. On the left is the form from version 341 that's currently active. So remember, things that weren't highlighted in yellow have been removed, but don't get worried. We may have just reworded some of these postoperative events. Chastity will explain that. Things in green are things that got moved around a little bit, either with parent-child relationships or located within the document in another location. So Chastity, you want to take it away?
Absolutely. So we'll start up with the postoperative section. And so your first question is patient expired in OR. So if you remember, we used to have a complication that said the patient expired in OR. This has just been moved over. So it's not a new field, but just been moved out of the complication section and into its own. And then if the answer is no, that the patient did not expire in the OR and you are older than 18, then you're going to fill out a few extra lab fields. And so these are creatinines and hematocrit and things like that. So pretty standard labs. And of course, we'll bring over the definitions from the adult database so that we have those. Melinda, is there anything you want to add here? Anything special about these labs, or are they pretty straightforward?
I think they're pretty straightforward. I mean, we're looking for the post-operative creatinine within 48 hours of OR exit because we want to monitor kidney function at that point in time. And then we're also looking at the creatinine, the peak post-operative creatinine prior to discharge. Those two numbers could be the same. Not often, but they could be the same. So just so you are aware of that. And then the discharge hemoglobin, discharge hematocrit, pretty straightforward. And then blood products used post-operatively. So this is blood products after the index procedure. So if they go back for, yeah, after the index procedure is how we defined it. I'm not sure you guys have, it might be a little different for congenital because you have, from what I understand, you have, you put multiple procedures in your database. Is that correct?
That is correct.
And we only have one index procedure, so I'm not sure how y'all are going to define that. So I'm sure you have a definition for that, which is not the same as ours.
Fair enough. Fair enough. We'll work on this, of course, in the training manual. So don't be alarmed. So the next section then is postoperative events. And what you will notice, which I think that this was one of the things that made me happiest, that we're no longer calling this section complications, but post-op events. So remember, we always try to educate and say, when we're coding these quote unquote complications, we're really looking at painting the picture of the story, you know, of what happened to the patient post-operatively. So what was their post-op course? What perhaps prolonged their stay or things like that. And so I think getting away from the word complication is probably good and really focusing on post-op events. These are things that occurred post-operatively. So the first thing you're going to notice is that first listed post-op event is now combined. So no events during the post-op time period was combined with the other one that said no post-operative events prior to discharge or on or before 30 days. So more of a combined, like there were no complications during the appropriate time frame for following up complications or post-op events. What you will also notice in this section is that things have been moved around, as Carol mentioned, and it's really about some parent-child relationships, which we'll see further down as we scroll down. There are a couple complications that were removed, and this is complications related to anesthesia and cardiac cath related complications were both removed. Cardiac dysfunction was changed around a little bit to low systemic cardiac output state. So that's the next change. Unfortunately, the whole field didn't go away, which I know a lot of you probably were asking for or looking forward to, but we're going to define this low systemic cardiac output state instead, which hopefully will provide a little bit more clarification as we're trying to code this field that we know causes us a little bit of grief from time to time. The pulmonary hypertension fields were then changed to something called severe pulmonary hypertension. And again, definitions will come out in the training manual, so you'll know exactly how to code these. When you get down further in the list, a complication, or I should say post-op event 150, you will see that the post-op post-procedural respiratory insufficiency requiring mechanical invasive and now to include non-invasive ventilatory support for greater than 7 days. So the patient that ends up, perhaps being extubated and no longer has an endotracheal tube on the ventilator, but is on perhaps CPAP or BiPAP. And that's where we're going to pick up that you are on that support for greater than 7 days or a combination thereof. When you look then further down the list with acute renal failure, the neurodeficit, thrombosis, you're going to see where these come into the parent-child relationships further on down. We then have some adult-specific complications. So these would only be eligible to be coded in patients that are 18 years of age and older. So Melinda, do you have anything you want to say about these adult events other than to be defined in the training manual?
Well, I mean, they'll certainly be defined in the training manual. I think that, and they're fairly self-explanatory when you're just looking at them here, iliac femoral dissection or acute limb ischemia, some type of aortic complication, since we're going to be putting aortic patients in the database, adult aortic patients, anticoagulant bleeding events, HIT, GI events, and wound complications. These will be defined in the training manual. So I'm not sure that there's much to add to it right now.
Nope. Totally perfect. Thank you. I appreciate you filling that in. All of the other post-operative events listed here are for all ages, including those that are older than 18. And then the ones in purple, again, are those that are just for the patients that are older than 18 years of age or older. Now, when we get into, when you've selected some of our existing complications, you will see now that you have some parent-child fields. And this is going to give us a little bit more granularity surrounding these post-op events. So if you selected an unplanned cardiac re-op during the post-op or post-procedural time period, you now get to select all that apply. So was that unplanned cardiac re-op for a residual or recurrent lesion? Was it reoperation for bleeding or suspected bleeding? Or was there a mediastinal re-exploration for reasons other than recurrent bleeding or suspected bleeding or a recurrent lesion? So this is where all of your mediastinal washouts and things may occur. So the nice part about this is, I don't know about you guys, but when I present, here's our number of unplanned cardiac re-ops for, say, Q1 of this year, the next question by my surgeons is, well, what were these re-ops for? And so sometimes that can be easy to pull out, and sometimes it can be more difficult to pull out. And so it's nice now that we can come in here and say, well, here are reasons that we selected this box. Same with an unplanned interventional cath procedure. So now we can come in and again select all that apply. So in the fact that the patient might have had multiple interventional cardiac cath procedures, you can select the appropriate boxes. So balloon dilation with stenting or without stenting, an intravascular intracardiac device placement other than a stent, recanalization of an occluded vessel, coiling of abnormal vessels, and then we've included IR drainage of fluid collections or IR lymphatic vessel occlusion. So these are some common IR procedures that we see in our patients, and so we're collecting those here as well. So the nice part is you're not just selecting unplanned interventional cath and then you don't know what the patients had done. You have a reasonable list, and then there's an other with free text. And so if there were other things that were completed during a cath, you can, or IR for that matter, that you can put them here. So I think it, again, gives us some more granularity locally for what's happening with our patients. So if you select an unplanned non-cardiac operation, again, we can select all that apply. And we have listed here some very common ones that programs, patients experience. So a diaphragm plication, a thoracic duct ligation, bowel resections, LADS procedures, enteral tube feeding tube placements, tracheostomies, vocal cord medialization, and vascular surgeries. And so I think, again, giving us some more granularity. These are the most difficult for me to go back and pull out when the surgeon asks for them, because I really have to go back, to every op note and see what patients had done post cardiac surgery. So if you've selected post-op mechanical circulatory support, you're selecting the type of mechanical circulatory support that the patient received, types, I should say. So an intra-aortic balloon pump, VADs, ECMOs, or the catheter-based VADs. Now, if you select acute renal failure, you only select one of these. And so the definitions will be largely unchanged, but it's clear now that we're to select one of these, that you had dialysis at the time of hospital discharge, temp dialysis that did not require dialysis at discharge, or temporary hemofiltration without the need for dialysis. And then for necrotizing enterocolitis, this is a new complication that's been added to our database, and that really came based on some data manager feedback that we always were writing that in free text field. So now you're able to collect it, as well as you can put if the patient was surgically managed for their neck or medically managed. Now, I think this one is probably going to be the most tricky, but again, we'll do lots of education surrounding this, as well as training manual. We'll have great definitions. But for neurological deficit, where we have had two different complications that said you had a transient neurological deficit that resolved at time of discharge, or that you had one that was persisting at time of discharge. So now if you select a neurological deficit, you're gonna first select the resolution. Was it resolved prior to discharge or not resolved at the time of discharge? From there, you would answer one of the appropriate child fields. So in the event that it was resolved prior to discharge, you say which of these or all of these that occurred for the patient. So was there a peripheral nerve injury, spinal cord injury, a stroke, subdural bleed, an intraventricular hemorrhage greater than grade 2, or some other unknown problem? And then likewise, the same things for a neurological deficit that is present at discharge. And so it may be tricky if a patient experienced multiple of these findings, and then some of them were present at discharge and others were not. And so we'll work through that in the training manual. And of course, we're here to answer your questions when the version does go live. But again, we just took the existing neurological complications and rolled them into one neurological deficit with parent-child fields. So then if you were to select a thrombus or thrombosis post-op event, now you can select the type. So intracardiac, central vein, pulmonary artery, peripheral deep vein, systemic to pulmonary shunts, and then systemic arteries. And so again, these are not new fields, they're just moving over from, you know, the list of complications that we would select. And then we have some greater than or equal to age 18 specific complications. So if you selected an aortic complication, then you can select the specific type of complication that occurred. And then if you selected an anticoagulant bleeding event, again, the type intracerebral, subdural, or GI. If you have HIT or heparin-induced thrombocytopenia, and you're greater than 18, there's some more granularity there, as well as the gastrointestinal event. You can speak to the type or types of events that occurred for these patients. If you were to select wound complication, now we can actually select the incision location. So sternotomy, thoracotomy, groin, neck, or other. And then if you were to select one of those types, there are some parent-child fields, or I should say child fields to this parent field. So in the example, if we were to select that there was a wound infection in the sternotomy, then we can select, is it wound dehiscence, wound infection, or sterile instability of the sternum. If you select wound infection, now you go on and grade that with superficial, deep, or mediastinitis. So the definitions remain the same, it's just moved around. If you were to select the thoracotomy site, again, you talk about, you can say, is it wound dehiscence or wound infection? And same for the other sites in the groin, neck, or wound other. All right, so then scrolling down into discharge and readmission. So now this section has been reworked a bit, but I think it's going to meet the needs of, you know, we had some mapping problems in the previous version, so we've taken care of that. And hopefully once on paper, I think it's really difficult to look at, but I think once it's in your software and you're utilizing it, it will make much more sense. So does the patient remain hospitalized during this episode of care? And you have a couple answers here. So you can say yes at this hospital. So in other words, surgery occurred at your hospital, the patient hasn't gone home yet. So we can say, yes, this patient remains hospitalized during this episode of care. If the patient has left your hospital and either gone home, you would say no, they're not hospitalized, or you would say yes and transferred to another facility. Because remember, when someone is transferred to another facility, you don't have a database discharge, but you do have hospital discharge. And if you select no, that they're no longer hospitalized, then you also have a date of hospital discharge, but database discharge date as well. So let's go through these. So if the patient remains hospitalized during this episode of care and your answer is yes, transferred to another hospital, or no, then you fill out this next section. Because of course, if the patient remains hospitalized at your hospital, you cannot fill out the date of hospital discharge yet, as they haven't gone home. So again, patient left your hospital to go home or to another facility. You fill out your date of hospital discharge and your mortality status at hospital discharge and your hospital discharge location. So these are nothing new and everything we're used to. Now, under that, you will have your readmission within 30 days. So if you don't have a date of hospital discharge, then you cannot fill out your readmission within 30 days of that hospital discharge. And this is only if your hospital discharge mortality status is alive, of course. Under this section, these have remained primary reason for readmission have remained the same, with the addition of a wound complication, since we know patients are coming in sometimes with wound dehiscence or wound infection or both. All right, keep scrolling down. And this is also where we have the fields of discharge with a nasoenteric tube or a G tube or jejunostomy tube. And then of course, our bad field remains unchanged. If a patient is transferred to another facility, these are some new fields, so let's talk through them. If they've transferred to another facility, we have a field now called end of database tracking and the status at end of database tracking. And then of course your database discharge location. So what this is allowing you to do, think of it more like your database discharge date, when you're going to be done tracking that patient. And we know that you stop tracking that patient if a patient has discharged home, died, or survived on chronic care status for greater than 183 continuous days. So now you're able to say, okay, on this day, my patient is done. I can, essentially discharge them or stop tracking them in the database. They are alive. And now I can select that the reason I can stop tracking them is because they discharged to home or that they survived in the chronic care center for greater than 183 continuous days. So we have a little more granularity now in these fields. And that was the purpose of doing this. When you complete this whole discharge section from date of hospital discharge, end of database tracking, and their mortality status at these time points, your date of database discharge will now be an auto-calculated field within your software. Same with mortality status at database discharge. So if you filled out all of the fields correctly, this will correctly define the status and your date of database discharge. And again, those will be auto-calculated and you don't need to populate those any longer. Then our status at 30 days after surgery remains unchanged, as do the method of verification. We then have the status, if alive, then your status at 365 days is also available. And then your status method of verification. We now have included your status at 2 years after surgery, as well as status at 5 years after surgery with the same methods of verification. And then unchanged are the operative mortality, your CHSS eligibility, and if they were the status of CHSS enrollment. And then into longitudinal follow-up. And you'll see here in longitudinal follow-up that this is largely unchanged. You have your date of last follow-up, because again, sometimes we follow up with these patients and they may not be at the 365-day mark, 2-year mark, or 5-year mark. This will give you an exact date of when you last follow up with the patient and their mortality status. And then of course, their mortality date, if in longitudinal follow-up, you find out that the patient is indeed expired. What is gone from here is the New York Heart Association score. Then into patient process measures. So in patient process measures, you'll see a few fields have been removed, and this includes the fields mostly surrounding the timeouts and handoffs post-OR or in the OR. So there is the one main question of, was there a conventional pre-procedural timeout? And the other ones have been removed. And so otherwise the section is largely unchanged until you get down to management and outcomes reviewed. And what you notice is the parent field that said, did the patient die or have major post-op complications, has been removed because many programs review whether you've had a major complication or not, and all deaths, and perhaps even regardless of specific op types. So we wanted to leave the field a little more open. And obviously the database itself upon analysis knows whether the patient experienced a major post-op event or not. So they don't need us to say yes or no. So if you have op type CPB cardiovascular, no CPB cardiovascular, or CPB non-cardiovascular, you'll complete this section, including now management and outcomes reviewed. And so again, upon analysis, we can figure out, okay, this patient experienced a major post-op event, and it was reviewed at conference or not reviewed at conference, and allow, we still put in the date in which the case was reviewed. Okay.
Very
And then
good,
we're on to
Chastity. You did
anesthesia.
awesome. Can we go to questions real fast before,
Yes, let's do that.
just in case? Okay. So the first one is from Jennifer. She's asking about the password protection on the data resource documentations, and that was an instruction from our executive leadership to put password protection on those pages. So we had that done, and it essentially is in line with many of the other registries have their information also behind password protection. And then Dr. Subramanian, I think this question probably is more in your alley. The question is regarding the updates for the CHSD reports.
Sure. Thank you, Carol. I'll take that.
Thank you.
Yeah, thanks everyone. Thank you for participating. Chastity, incredible job as always. I learned a lot. Thank you. With respect to the CHSD analysis, there have been some setbacks in the analytics for this last data harvest that closed. What we have found is that some of our logic was not utilized correctly in the reports. And as we've told you before, we identified this once in the past, and we continue to be working now, both with our partners IQVIA and DCRI, to relook at all the analytics to make sure that they are appropriate. We're all fully aware that the delay in release of the analytics is a challenge. It's a challenge to many of the programs, including my own. We fully recognize that. But I think all of us will agree that having an accurate, reliable, and good quality analytical report is far more important than having an inaccurate one that's released on time. So in keeping with that principle, we are intentionally taking our time to ensure that the analytics are done as per the logic, so that the report that we release is reliable and accurate. That's taken a long time. It's still not ready. We discussed this at our last task force call a week ago. We're working continuously, both from the surgeon leadership and from the STS staff and leadership, to get these analyses done. If I might guess, and it's purely a guess, I still think we're a few weeks away from being able to get a proper analytical report released to all our participants. What that would also mean for all the participants and you data managers is that we will be revising the date for our next harvest close. We're not going to close this current ongoing harvest until the prior harvest analyses results are released and you all have had a chance to take a look at it closely and make sure that there aren't any data corrections that need to be done. So all of that is in the work, continues to be a few weeks away. We really apologize for the delay, but I hope you will all agree that we have the right principle in mind, which is even if it's late, we want it to be accurate. I'm happy to take any more questions in that regard. Back to you, Carol.
Thank you so very much, Dr. Subramanian, for answering that question and providing the detail around it. Appreciated. Okay, Chastity, this question is for you. Does STS define acute kidney injury as acute kidney failure? And
no, so we're really looking to collect not just acute kidney injury, we're really looking to collect where dialysis was required so that you actually have renal failure or kidney failure. And so we know a lot of patients post-op may have an acute kidney injury, but you're not coding acute renal failure unless some type of temporary, permanent, or dialysis or hemofiltration was required.
thank you. Will wound complication only refer to surgical wounds related to CT surgeries and not incisions related to non-cardiac re-ops?
Well, that's a great question.
We can take it back and review it with the surgeons when we're
Yes, we may
working on
have
the
to,
manual.
because obviously some non-cardiac re-ops could be thoracotomies that are done by cardiac surgeons, and so again, in the spirit of things being post-operative events, I would think we would want to collect an event that occurred with the patient, regardless of who the surgeon was. But again, you're right. We need to take this back and discuss with the core group, and maybe this will be our first, question on the new version that gets added to the training manual. So I appreciate your question, Krista, and I'm writing it down right now.
I see Dr. Meyer has his hand up. So Dr.
Yes.
Meyer, please feel free to jump in here.
Yeah, I was thinking that, the question might relate to the patient who has, for instance, a gastrostomy or some other non-cardiac operation. And if there was a wound infection around that, or potentially even around a Broviac insertion site or something like that, I'm not sure I would think that was appropriate to count that. But I don't know. I think you're right. We should sort of hash that out a little bit in the core group.
Okay, thank you. Thank you, Chastity. Thank you, Dr. Meyer.
Yeah. Can I just take the prerogative here and ask one question. Can you go back to the, the fields where there's all the database discharge and, the auto calculation of the dates and things like that?
Oh, let me find it. Yep.
Right in there. This field that says end date of database tracking. Should we just clarify that a little bit, because it's for this admission, right? Or for this episode of care, because we don't want people to not collect the data at 12, 24, and 60 months later. So I just wanted, maybe that's a minor detail, but seems to
So
me.
I think much like the 365 days is separate from database discharge, we would keep the
Yeah,
status at those time points separate from the episode of care and the
Yeah.
database tracking. Yes.
I don't know, maybe I'm just, focused on the semantics here, but we're still tracking for the database, right? So, I
I
think,
see what you're saying, Dr. Meyer. It could get confusing, so we should work on that
yeah,
terminology.
I think I just, if you just added, database tracking for this episode of care,
Great. Yep.
or something, to make it clear that we don't want people to then not pay attention to the subsequent follow-up information that we're trying to acquire.
Perfect. Yep, we'll do that.
Thank you.
Thank you. Thank you. Chastity, are these discharge complications multi-select? So I'll go back up here.
I'm assuming you mean the parent-child relationships for some of the major complications. So the entire post-op event section is multi-select unless you hit no or no events. So then it's not multi-select. All the rest you can select as many as you want. And then when you get into some of these major ones like unplanned cardiac reops or non-cardiac operations, you can select, all of them are multi-select with the exception of dialysis, because only one of the dialysis complications should be selected, but everything else should be multi-select.
Thank you. Won't the end date of database tracking always also be the calculated discharge date? Yeah. So the database discharge date is pulling from the calculated database discharge date is pulling from two fields. It's either going to pull from this end of database tracking date, which can only be filled out for patients who are transferred to another facility, or for patients who are discharged from your hospital, it would pull from the state of hospital discharge.
Mm-hmm.
For post-operative section, is this specifically asking about M&M conference? Post-op review. Is this specifically asking about M&M conference or any conference form that the institution may have?
Krista, I'd have to look at the specific definition, but I think the whole point is that the case was discussed and reviewed, the management and outcomes. And so if you call that an M&M or some other type of conference where you discuss these, it should meet the parameters.
Can you repeat what was stated in the beginning of the meeting about the changes to the STS login? Sure. So your username and password that you used for AQO will be required. It's actually your STS login, which is what we use for AQO and other things that are kept behind our password protection here. But you will need that information to access your data collection resource information. If you don't have that information or you don't remember it, you can contact member services. Or when you go to click on this link, you'll see a gray box that says get started to help with resetting your password. And okay, next question. Love the new changes in the complication and process measures. Thanks. Question on the last process measure question related to management and outcomes reviewed. All of our VAD and ECMO runs are reviewed, even if there wasn't a complication. Should we go ahead and capture these review dates, even if there were no complications? Chastity?
Let me just scroll to this section to make sure. I believe that that question will not pop up for those op types,
Oh, good call.
right? Because it's
Yeah.
just op type, CPB cardiovascular, no CPB cardiovascular, or CPB non-cardiovascular. So we don't collect the patient process measures on VAD or ECMO thoracic op types.
Okay, and then I'm gonna go down here to a question. It says, this is for Dr. Subramanian. What is the purpose of collecting data 5 years out? Have you considered the resources for an organization to track patients 5 years out? Dr. Subramanian?
Oh, great. Yeah, this is an excellent question. Thank you for asking this. Yes, we have. And this is an intentional direction that the database is taking with a lot of input actually from surgeon members, participants, and families. I think more and more as the in-hospital, the so-called database mortality improves for children undergoing congenital heart disease, I think all of us need to start looking towards more longitudinal outcomes. And so at every data version upgrade, we have tried to extend the duration of follow-up for as long as possible. So, in the last upgrade, we took 1 year data, and now we're taking 2 and 5 year data, because it's the longitudinal follow-up, it's the longitudinal how they're doing 4 or 5 years after the surgery, which I think it is where we as a specialty should be moving. Now, the question is very, very valid. There's a lot of effort involved in collecting this. We understand that. We're encouraging the individual participants to do the best that they can. We know that in many institutions, they are followed locally, and it's just to look into the EMR system, EHR system, to get this information. At the same time, there are several institutions, ours being one of those, where patients come from afar, and this could involve a substantial amount of resource burden. If there's a mechanism for you to do it, I think it would be great. It really would strengthen us, not just as a database, but it would strengthen all of us as a specialty in being able to follow longitudinal outcomes. So thank you for the question. I recognize that it has a resource burden, and we all hope you'll be able to do the best you can to keep the specialty moving forward. Thanks again. Back to you, Carol.
Thank you very much. I have another question for you. Well, I guess I can just take this one. It says, will an email be sent out to data managers informing them of the delay of the harvest? And the answer to that is yes. We're just waiting for some additional information to come back from our analytics center before we send out formal communication, and which will include a new harvest close date, as well as Dr. Subramanian had addressed earlier. Temporary filtration includes filtration through ECMO circuit and not just CVVH. Chastity?
Yes, I believe that that's correct. So any type of temporary hemofiltration would be included here. We don't differentiate as some of the other databases do.
Thank you. Angie Evil, I see your question. It says for ECMO incisions, when cannula is not inserted by cardiac surgeons.
I think she's speaking to the infections in surgical sites where there are non-cardiac operations, and making a plug for perhaps coding them as we'll discuss with the core group later. But saying that while that's not a cardiac surgery, we could have incisions that have infections where, another surgical group has made the incision or done the procedure.
Oh, I understand. Thank you.
I think if I'm reading Angie's brain.
It sounds like you got it. Okay, read the M&M question from the training manual. Reviewed at conference, this patient's management and outcomes were reviewed as part of a regular scheduled quality assurance, quality improvement cardiac care conference, i.e. M&M conference. Yep, so exactly what Chastity has said, that is one type of quality conference. There's other conferences you have with your surgeons, your monthly CV surgery or congenital surgery meetings where you go over your results with your surgeons, or where you're standing on the monthly basis or even quarterly. The M&M is one type of those meetings. Next question from Becky. If a person is not a member of STS and is not a past attendee of AQO, is there an option for them to create a username and password to access the data resource? Many of our research folks use this website to review fields available for local research requests. That's a great question, Becky. So if the people on your team, on your research team, are listed on your as a participant contact for your database agreement, they will have access. We do not want to hinder any type of research being performed at site. So if there's specific requests that they need, maybe you could help them out by downloading that material and sharing that with them, or they can always reach out to us and we'll help them with whatever they need for their projects. I'm confused about the 5-year follow-up. If we only submit 4 years at a time, won't there be a time when we always have to go back and submit 5 years ago, or am I just very confused? Anybody?
I can take that. This is Janet Kreutzer. The whole demographics file goes each time, and the cases for the time frame go. So your whole demographics file goes. So anything that's linked to your demographics field gets updated each time you submit.
Great, thank you, Janet.
Hey, Carol, it's Leslie. That is, as it is right now, I think a event level field. So we might need to look at that.
Oh, what level field?
Event, it's attached to the surgery, not to the demographics table.
Okay, well, we can, yeah, let's review it and see. Okay,
Good point, because the follow-up date is attached to the demographics, so that would go.
The longitudinal follow-up would go, not the 2-year and 5-year, right?
Right, the longitudinal follow-up will go. So that probably needs to get relinked somehow. Good point.
we can talk more about that as we're going through the training manual build and come up with some very clear direction on how sites should be doing that. Thank you so much. And this is for Dr. Subramanian. Thank you so much. She's just trying to balance workload. So thank you for the information on the 2-year and 5-year follow-up. Okay. Any other questions? We have about 15 minutes left. Do we want to go into the anesthesia section? Maybe see how far we can get here. There's some significant changes. It's
absolutely fine with me. There's not a lot of changes, so we can definitely get started. So the administrative section has not changed as anesthesia data being collected and anesthesiologists present. So none of this has changed, and down into the types of providers present. So when we get into the anesthesia preoperative section, there's now a new parent field that says preoperative medications taken, yes or no, and now a multi-select category for the different medications. So again, you can select all, but what you also will see are the addition of some new medications, including supplemental iron, EPO, and then preoperative pulmonary vasodilators and preoperative anticoagulation. So if you select one of those, if you'll keep scrolling, Carol, if you select one of those, you now have some new child components. And so select all that apply. And so when you select pre-op anticoagulation, you can now select aspirin, Coumadin, direct fibrin inhibitors. So these are not new fields other than the novel oral anticoagulant like apixaban or Xarelto. So that's new. And the addition of, for example, bivalirudin for direct thrombin inhibitors. Otherwise, these were already in the list. They've just been moved under a parent-child relationship field. If you selected pre-op pulmonary vasodilators, you now can, again, multi-select all that apply. So endothelin antagonists, nitric oxide, PDE5 inhibitors, or prostacyclin. And so again, all of these listed before, but they've just been lumped into a category. Upon analysis, these get lumped into these types of categories anyway. And so now they're just allowing us to do it on the data collection form. And so as we scroll down, we don't see any changes to the oxygen sat or supplementation or time of arrival or anesthesia start time. So now when we get into anesthesia monitoring, you'll see the change in these fields. The fields themselves haven't changed. Oh, sorry.
Sorry for interrupting, Chastity. Did you want to talk about the removing of the preoperative sedation, or did you already say that?
Oh, no, I didn't. I was looking to the right and not to the left. So yes, the preoperative sedation fields have been removed from the anesthesia section. Okay, so then into anesthesia monitoring. So what you're going to see with these fields is they're essentially the same, but they've become multi-select fields. So instead of yes, no's individually to your arterial line sites or your central venous pressure sites, now you just select the ones where you had the monitoring occur. And so you can select multiple arterial line locations or central pressure monitoring sites. And so same fields, just different flavor. So keep scrolling down again for the same for our central pressure monitoring. Ultrasound guidance, they now, ultrasound guidance used for catheter placement is just yes or no, not arterial line only, central venous line only, or both. But what you do is, again, multi-select which catheter was ultrasound guidance used, and then the same for neurological monitoring. Instead of a bunch of yes, no's, you've got a parent-child relationship with yes, and then you select the type of monitoring, all that apply. No changes then to the lowest recorded intraoperative temps locations, or if there was a transesophageal echocardiogram done. So then as far as anesthetic techniques, you can see we've taken out the fields inhalation, intravenous, and IM for induction types. And it looks like we go right into regional anesthesia, which again have become, these have changed a little bit too. And this is really in relation to many of the questions that data managers have posed about the regional anesthetic sites. So hopefully it'll be a little bit more clear, and we'll provide some more clarification in the training manual regarding these. They have added some new regional anesthetic sites. And so erector spinae blocks, we get lots of questions about those, some of which have been my own. And then the transverse thoracic blocks and intercostal blocks. And so again, a little bit more granularity in this section. And then let's see, looks like we've moved around the regional field block to call it an incisional field block by surgeon or anesthesia. So just a change there. And then we go into the airway questions. We've taken away some of the fields here. So airway size, if an LMA or ET tube size have been taken away. And so they're really just looking at what type of airway was used, was it cuffed or not, and what site, being oral, nasal, or a tracheostomy. Then we get into intraoperative pharmacology. And so again, we've added methylene blue here. Calcium chloride and calcium gluconate, I believe, have become one field, or maybe before, yes, they were two separate fields, and now they're just one combined field. So if you gave one or the other, you would select 70. And as we keep scrolling down, you'll see that some have been removed from the list, so including narcotics and benzos and things like that. So then let's see, the blood section, is that what this is? Or no, I'm sorry, it's the bleeding section has been completely changed around. And so we'll hit that later on in the anesthesia data collection form. So then pharmacology on arrival to the ICU, you can see that some of these have been deleted. So Amicar, aprotenin, benzos, narcotics, tranexamic acid, ketamine have all been deleted. And so you see the list in front of you, otherwise is largely unchanged with the combination of calcium chloride and calcium gluconate. And then we get into our anesthesia ICU PACU care, and I believe this section is largely unchanged. And then the anesthesia adverse events, I believe, are also largely unchanged. A few words now, finally, like vascular access. All it said before was vascular access. Now it's saying that it took you greater than 60 minutes to obtain vascular access prior to the start of the case. Is this a good stopping point? Because I think we have a few more questions, and we pick up with blood next week.
Yeah, I think that's good.
Is
And
that
then
good?
we can,
Okay.
yeah, we can do blood next week and complete. We just have 3 pages left. And then we can take any additional questions next week that come up.
Okay.
There are 2 questions here. If Dr. Subramanian is still on and wanted to take this one, you're welcome to it. The question is related to the stat scores. It says, I know this is an upgrade webinar, but I have a question regarding the new stat scores in the spring 2022 harvest. Will the data be analyzed using the new combination codes, e.g. 5002 transplant plus P reconstruction, or no, because we cannot use these codes until the new version goes live?
Yeah, thank you. Thank you, Amy. So only the new stat scores, the 2019 stat score codes are being implemented for the spring 2022 harvest when that happens. Only the new stat scores. The new combination codes, you are correct. They will not go into vogue until the new data collection form becomes available.
Thank you very much. Chastity, this one is for you. I thought I heard the anesthesia section is only intended for CPB, no CPB cases, not for minor or other types. Does that mean that anesthesia section won't open for minor or other types of procedures?
If I said that, then I said that in error. I don't know that to be true because I don't see that the anesthesia section is built on a parent-child field to op type. I thought it was anesthesia data being collected, yes or no. So if you hit yes, then this should open.
I agree. I didn't hear you say that, but, and I agree, we didn't make it that way because I think all sites like to collect this, sites that collect anesthesia like to collect it on all of their cases.
I think that perhaps what you're saying, Diane, is that anesthesia is saying, it used to be historically that they wanted anesthesia data collected in anywhere where cardiac anesthesia was utilized. So like IR suites or other operations and things like that. And then they said, they came back and essentially said, hone in all of your data collection on your cardiac operations. When they said cardiac, I don't think they meant just CPB, no CPB. I think they're just saying surrounding your cardiac surgeries as in done by your cardiac surgeons, not IR, not cath lab, not G tubes placed in cardiac patients. Does that maybe better answer your question? Okay.
She says, yes, that's what was meant. Mm-hmm. Thank you. Oopsie. Dr. Subramanian, just to clarify, all transplants will be analyzed as stat 3 cases in the spring 2022 harvest.
You know, I don't remember off the top of my head what the stats code is for them, but whatever their stat 2019 scores are, that's the score that they will get in the current analysis.
Thank you very much. Okay, and it looks like there's a TEE question in process measures and also an anesthesia section. Do these have different meanings? So let's find the one up here in the process measures.
I don't believe they have different meanings, but I guess what I would say, well, one is available for the case and was it performed? And then I think in the anesthesia section, it is just if it was performed.
Yeah,
So
this is intra-op TEE available for case.
But the difference would be not all sites collect anesthesia data and not all of the anesthesia collected data. Perhaps if you're collecting anesthesia data on an ECMO case or otherwise, it won't open the patient factors fields. So sometimes you might be answering it in both places, and in other times it may be one or the other, depending on the op type. Or if you're collecting anesthesia.
Thank you, Chastity. In reference to the pre-op factors, there was a field for respiratory syncytial virus, RSV, but not for other viruses, rhino, etc. Has this been revised?
Let me go back to pre-op factors to see.
Let me see if I can get up there. I don't think that we included the other viruses.
I don't think so either. We left RSV.
And I don't believe we included, I think there was discussion on it, but
I think ultimately they decided no.
That's correct. Yeah, that's what I remember.
Yes, I don't see it, but there is still other where you can write that in.
Okay. Just to clarify, all the new stat scores in Appendix C are for the new version in January?
No.
So I think what we probably need to do is go through that appendix C and highlight ones that are going live in the spring with the spring 2021 report, and ones that are going live with version 6.23. That
Yes.
probably, if that we could do that, that would probably be really helpful.
The ones that are highlighted in blue are the new 6.23 codes. So those would not be included in this spring 22.
Okay, hold on.
Yep. And there, we did this on a webinar not long ago, one of the education webinars where we talked about, so it may have even been the one we did a few weeks ago, the most recent one, because
So
I had a
this is-
picture of,
Yeah, maybe we need to put on here what the blue means.
Yeah, it's down in the
it is.
in the footnote at the bottom.
Oh, good.
Yeah, so I
Hey, Ann,
can.
you're so good.
That's okay. I can make it a little bit more prominent and repost it. So, or put it at the top just to make it more clear.
Yeah.
Hey, Leanne and Carol, can we also just quickly highlight that right now, the things that have been submitted through 2021, the next report we're getting is analysis as usual, correct?
Correct.
Right,
Then
that was the
following analysis will take into the new appendix scores. And then after that, we will go live with 623.
And we can
Right.
we can run through this on our next education webinar as well, just to clear up any confusion and cover it again, just to go through it again.
Yeah, the new stat scores, the ones not highlighted in blue on this appendix C, will be implemented with the spring 2021 harvest close, which is currently set to close in May, but will be likely delayed, and we'll let you know more on that date. The data that's currently in analysis is the fall 2020 report. These new codes that are on this new appendix C that are not highlighted in blue, the white ones, they will not be implemented in that report. They will be implemented in the spring 2021 report. The codes in blue go live with the version 6.23 upgrade, which will be OR date starting with January 1st, 2023. Okay. Stat 2019. I don't know if you want to take this question or not, Chastity, from Amy. I think we're good.
Yeah.
I think she was the one discussing with Dr. Subramanian.
Yeah.
So correct, you cannot use the 5002 code yet because that is not available until 6.23. The data that is currently in the warehouse that we've already submitted and we're waiting for the reports to come out will be the old stat scores. The data that we're going to turn in May, but likely be extended, will be the new stat scores.
Thank you. Okay, well, I think we covered everything. I want to say thank you so much, Chastity. Thank you, Dr. Meyer, and thank you, as always, Dr. Subramanian and Dr. Jacobs, for all of your help on these calls. Thank you, Leanne. Great job. And we will revisit Appendix C in the next webinar just to go over it one more time and be really, really clear on what's happening, both with the data that you're expecting back from analysis for the fall 2021 report, what's going to happen with the spring 2021 report, and what's going to happen in version 2 when version 6.23 goes live with OR dates starting January 1st, 2023. So we'll go through that again and make sure we're all on the same page and answer any questions that you have. So I just want to say thank you so much, everybody. I hope you have a great rest of the day. And thanks for joining, and please take care. And
Great job.
Thank you. Thanks, everybody.
Good job, Chastity. Thanks, everyone.
Thank you.
Great job, Chastity.
Bye-bye.
Bye, everybody. Have a great day.
Too.